We've talked about mood episodes. We talked about mood disorders, and you should all know the difference between a mood disorder and a mood episode. And now we're going to learn about subtypes. So here you got them. There can be a mood disorder, often major depressive episode, with melancholic features, with atypical features, catatonia, psychotic features, anxious distressed, mixed features, a seasonal pattern, rapid cycling, and with peripartum onset. So we'll go ahead and define the important ones here. So subtype is applied to a mood episode, not a mood disorder, and it demonstrates certain features or characteristics, and it has implications for both prognosis and for treatment. So again, here they are. So mood episode with psychosis. Psychosis involves hallucinations and or delusions, and psychotic symptoms can occur during a manic or a depressive episode. Now, if psychotic symptoms are present in a mood disorder, they occur only during the actual mood episode. Once the mood episode resolves, so do the psychotic symptoms. So they're not allowed to have psychotic symptoms outside of a mood episode. Now, if one of you came to me and you met criteria, say, for a major depressive episode, I would still ask you, regardless of how well-kempt you are and articulate, I would still have to ask you, are you hearing voices or seeing things that other people don't hear or see? Do you feel like you're in any kind of danger, such as somebody's following you? I ask these questions because the patient may not bring them up, and they can be subtle. I did a combined internal medicine psychiatry residency, and in my 5th year, I was working in an outpatient medicine clinic, and one of my long-term patients, who I'd been treating for depression and anxiety, is brought in by his wife. The wife asked to speak to me privately. She says, "Dr. Dantz, Jesse has been talking to himself as he's been going up and down the stairs in our house, mumbling to himself. And when I asked him, well, who are you talking to? He said there were people telling him to hang himself." So I was kind of shocked. I brought the guy in and I said, "Jesse, your wife tells me this and this." He nods. I say, "How long has it been going on?" And he said, 6 months. But I'd seen him like every month or two during that period, and I said to him, "Well, why didn't you ever tell me about this?" He said to me, "Because you never asked." And that was one of the greatest teaching lessons for me during residency, which is I've got to ask. Mood disorders with psychosis actually have a much higher risk of suicide and self-harm than a mood episode without psychosis. You'll notice that now I'm using disorders and episodes kind of interchangeably, but that doesn't mean anything different than what I've told you already, is at this point we're taking it for granted the person has a specific disorder comprised of depressive episodes and or manic or hypomanic episodes. Okay, so let's talk about mood disorders with peripartum onset. Used to be believed that when a person's pregnant, oh, they should be so happy. No, they're protected against depression. Not true. Same incidence of depression during pregnancy as in other times during a person's life. Complications of depression affect the mother, the baby, and other children. Postpartum is a particularly vulnerable period. So there's a spectrum of postpartum mood changes. 2/3 of women have the postpartum blues. Comes in maybe 3 days, lasts about 2 weeks. There is crying spells, irritability, clearly there's sleep deprivation, but it's transient. Usually they can respond to some reassurance, although they can be quite irritable. But it goes away within 2-3 weeks, and it doesn't meet criteria for a major depressive episode. Then you've got postpartum depression, which, when it occurs, starts a few weeks after delivery. The majority have the onset before 6 weeks of postpartum, but there are several who can have it up to 3 months or longer postpartum. That's got an incidence of 10%. So 10% of women postpartum are going to meet criteria of having a major depressive episode. We call that the peripartum depression. Now, 1 in 1,000 women will have a postpartum psychosis. Most of these are in the setting of a major depressive episode or even a manic episode. So 0.1%. That's low, 1 in 1,000, but if you're an OBGYN, you're going to see it because you'll be delivering thousands and thousands of babies over the course of your career. This is actually a medical emergency. Postpartum depression has the same risk factors as depression before pregnancy. Same prevalence, although people have argued about that. It used to be thought that there's an increased prevalence of postpartum depression than previously, but recent studies suggest it's same prevalence, about 10% in any point of time of women will meet criteria for a major depressive episode. Same symptoms, but now there's a baby involved. So postpartum depression has some very interesting distinguishing features. Often it's focused on the infant. There's a recurrent obsession, oh my God, I might drop the baby, I could drown them, I could stab him, put him in the oven or microwave, visions of sexually abusing the infant, thoughts that someone will steal or harm the infant. This doesn't mean that the patient wants to. They don't want to do it at all, but the thoughts are coming in and they're like a helpless victim to these thoughts that they just absolutely have no desire to do. They want to protect the baby. But this may be so severe that they're going to stay away from their infant. They'll stay away from scissors or knives that could potentially stab the infant. And it can clearly cause a disruption in mother-infant bonding. So the compulsions that are a response to these obsessions, like I said, they avoid holding baby by staircases, avoid bathing the infant, hide the knives, avoid kitchen, avoid changing diapers or bathing, and avoid leaving the house. Postpartum psychosis, again, 1 in 1,000. The most famous case is Andrea Yates. She had, don't remember how many children, I guess here I think she had more than 4 kids, but and each time she had a child, she had a severe postpartum depression. And at least 1 or 2 of those were with psychotic episodes. Well, in the last baby that she delivered, shortly thereafter, predictably, because she'd had these episodes before, she became psychotic. She drove all of her kids to a lake and drove the car into the lake, drowning and killing herself and all of her kids. So we've talked about some of the subtypes. I want to give you just a quick rundown of some of the others. Melancholic features is associated with major depressive episodes, and that's when the person has early morning awakening, so they have insomnia and they have marked decreased appetite and they have psychomotor retardation. Atypical features are characterized by a major depressive episode with excessive sleepiness and increased appetite. And those are the major distinguishing features of melancholic and atypical. There are other criteria, but that's what I want you to know is atypical is overeating, oversleeping. Melancholic is decreased sleep, often early morning awakening, and decreased appetite. Catatonia we described when we went through the mental status exam. So 50% of catatonic episodes are in the setting of either a major depressive episode or a manic episode. Psychotic features we talked about. Anxious distress is when the person has both a major depressive episode and concomitant anxiety. About 60% of people with major depression have concomitant anxiety. Mixed features is interesting. That's when a person meets the criteria of a major depressive episode or a manic episode, but they also have some features of the opposite pole. So you can imagine an individual who's grandiose, has decreased need to sleep, thinks he's the Messiah, and meets all the criteria for a manic episode. But on the other hand, he's feeling difficulty concentrating. He has decreased appetite. He certainly needs less sleep. He may be beginning to experience low self-esteem because no one is acknowledging that he's the Messiah. And he certainly could have suicidal ideation because no one is accepting he's the Messiah. So you could have a major depressive episode with mixed features or a manic episode with mixed features, depending on what the predominant state is. Not incredibly important, what I really want you to know is that a person can have mixed features of both depression and mania. Seasonal patterns, which is essentially seasonal affective disorder. Rapid cycling is given to people with bipolar disorder that have 4 or more mood episodes per year, and we also discussed peripartum onset. So you should know the basics of these. No need to kind of memorize criteria. Just know the basics that distinguish these different subtypes.